here again with another overview video. Today we're talking about cellulitis and erysipelas. Alrighty, let's get stuck in today. 36-year-old man is brought to the hospital by his wife because of rapidly worsening skin infection. The patient has a history of our beloved type 1 diabetes mellitus, and his last documented A1C is 5.5%, not too shabby. His wife reports that he has had a small insect bite, oh dear, on his calf a few days ago with some redness. Over the course of today, he has since developed severe pain, initially with no redness, but over the last 1 hour, there has been a worsening pain and swelling with some mottling of the skin. He also reports that he feels like his thigh and calf are numb. Oh, ho, ho, ho. He is febrile and tachycardic. Physical exam reveals marked tenderness and tenseness of the right leg from the thigh down. There is some redness and mottling. A femoral and posterior tibial pulse are present. CT scan of the leg shows extensive inflammation of the fascial plane, but no evidence of muscle inflammation. Which of the following organisms is most likely responsible for his infection? Is it A. Clostridium difficile, B. Staphylococcus aureus, C. Staph epidermidis, D. Strep pneumoniae, or E. Strep pyogenes? Let's get stuck in, guys. What really is cellulitis? Well, cellulitis simply refers to the acute spreading inflammation of skin and subcut tissue with local pain, swelling, and erythema. Once you see it, you can recognize it very easily. It may be secondary to either infection, which is acquired either during surgery, could be post-burns, or fungal infection in the toes or feet. Now, skin on the face or the lower limbs, especially has a predilection for the shin and ankle, are commonly affected, though cellulitis can really occur on any part of the body. It appears as a swollen, red, angry area of skin which is hot, 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 tender, and may spread rapidly. If left untreated, the spreading infection may rapidly turn into a life-threatening condition. As always, some beautiful images courtesy of short cases in clinical medicine. Here we can appreciate the red, angry, kind of erythematous, tender, hot lesion, which indicates cellulitis of the right leg. Similar situation here, cellulitis of the left leg. Note the discoloration. Cellulitis of the left arm. And you know the cardinal signs of inflammation. Rubo, calo, dolo, tumo, functio, lesa, which is rubo is redness, calo is heat, dolo is pain, tumo is swelling, and functio, lesa, loss of function. All of these are present to some degree in a patient with cellulitis. Here we can see cellulitis of the right hand. So what are the causes of cellulitis? Glad you asked. So mainly it's group A, Strep pyogenes, right, or Staph aureus. And bear in mind, if the patient's diabetic or immunosuppressed for whatever reason, they could be on steroids, it could be HIV, diminished nutrition, solid organ tumor, and the list goes on. Then you think about atypical organisms causing cellulitis, like gram-negatives or anaerobes, right? What is the treatment for cellulitis? Well, antibiotic is the name of the game. Phenoxymethyl, penicillin, erythromycin. But what's very common in our setting is using clox. So either IV clox or oral flucloxacillin, cefalexin as well can be used. In severe cases, you want to use intravenous antibiotic, which is then followed by oral therapy. In recurrent cellulitis, low-dose antibiotic prophylaxis with phenoxymethyl penicillin 500 mg should be given. What investigation should be done in cellulitis? Well, obviously, most likely it's a diagnosis on inspection, but to confirm, you can do a full blood count, which will obviously show a marked leukocytosis. Erythrocyte sedimentation rate is up. Do a blood glucose, especially to exclude diabetes, or in a diabetic patient to gauge glycemic control. CRP, C-reactive protein, Doppler study of the lower limb vessels if you want to exclude a deep vein thrombus sitting there. What are the differential diagnoses for cellulitis? Well, deep vein thrombus probably tops the list. It could be trauma, acute arthritis, and a ruptured Baker's cyst. Now, what is erysipelas? Sounds like Mexican food. Not really, you don't want to eat this thing. It is an acute superficial form of cellulitis which occurs classically in the cheek. It's very cheeky, this one. It may occur in really any part of the skin, caused by our infamous beta hemolytic streptococcus. Now, infection usually involves the dermis and the lymphatics. So you may have a degree of lymphedema accompanying this. It is a more kind of superficial subcutaneous infection than is cellulitis. What are the risk factors for erysipelas? Extremes of age. if you're really old, if you're really young. So elderly and infants, kids, diabetes mellitus, alcoholism, immunodeficiency, lymphatic obstruction. The differential diagnosis for erysipelas is cellulitis, contact dermatitis, angioedema, herpes zoster, and treatment and complications. Treatment, antibiotic is the name of the game. So penicillin, clindamycin, erythromycin, which can be given oral or IV. Complications of erysipelas is obviously septicemia. If it gets into the bloodstream, glomerulonephritis, often caused by the underlying strep infection, necrotizing fasciitis as in our clinical case, recurrent infection, and lymphatic drainage. So back to our clinical case, guys. We had a middle-aged man with type 1 diabetes, an insect bit him on his cuff, and now he has developed severe pain but no real redness, and there's some skin mottling, right? And he has anesthesia or hypoesthesia of that affected limb. He's febrile, he's tacky, right? CT shows extensive inflammation of the fascial plane, but no evidence of muscle inflammation. What's going on? What is the infection behind this? And the answer is strep pyogenes. So necrotizing fasciitis involves the superficial and or the deep fascia investing. It's an investment that they make for the future of the muscles of an extremity or the trunk. Now the source of infection can either be the skin with organisms introduced into the tissue through trauma, sometimes trivial, or bowel flora with organisms released during abdominal surgery, or from an occult enteric source such as diverticular or an appendiceal abscess. In this case, the presence of fasciitis without, listen, you've got fasciitis without myositis, makes strep pyogenes the most likely organism. Here's a fun picture from Mr. Muniz et al. At MedComic, demonstrating necrotizing fasciitis and outlining the intense pain, erythema, tissue crepitus, and systemic toxicity, right? And noting that it's rapidly progressive and often fatal infection of the subcut tissue and the fascia. Here we have risk factors as we outlined. It may be polymicrobial in nature, and imaging will demonstrate soft tissue gas, right? Much of for Clostridium perfringens there. And surgical emergency. Necrotizing fasciitis is a surgical emergency that requires aggressive surgical debridement and IV antibiotics. God bless you, MedComic. So guys, I just want to talk about salvation, which can be found in Jesus Christ alone. The book of Hebrews chapter 9 verse 27 through 28 says that it is inevitable that we are going to die one day, just as people are destined to die once, and after that to face judgment. So Christ was sacrificed once to take away the sins of many, and he will appear a second time, not to bear sin, but to bring salvation for those who are waiting for him. The book of John 14 verse 6, Jesus Christ says, I am the way, the truth, and the life. None comes to the Father but by me. Beloved, there's only one way to salvation, and that is through Jesus Christ alone. God bless you. Here are my references. I'll catch you soon with another informative video in internal medicine. God bless you.